The next organ system I would like to go over is the neurological exam. I'm going to cover stroke, delirium, and syncope. And I also have a physical diagnostic test that I think it might behoove you to be proficient at. Now, stroke assessment is typically done by assessing quickly for weakness. With the Cincinnati Stroke Scale, you check to see can the patient speak clearly, can they grimace with their face, and do they have any weakness in their arms. And that can be tested many different ways. The patient is obviously going to be speaking to you. If they're not speaking to you, you've learned that pretty quickly. You can ask them to grimace with their face. You can ask them to grip your fingers tightly. You can ask the patient to simply hold up their arms and see if they are having trouble holding an arm up. One thing that you want to ask is, do you have a seizure disorder? Because patients can have a seizure and then the seizure is over by the time you get there, but they may have some residual unilateral neurological signs called Todd's paralysis. The other thing is the patient that tells you that they're having a headache. A headache is clearly not a symptom of an ischemic stroke, but it definitely is a symptom with a hemorrhagic stroke. And so a patient particularly that offers the history of, I have the worst headache I've ever had in my life, that is a cerebral hemorrhage of some sort. One thing about the history that is not going to be important is the patient who says that they're dizzy. Dizziness is almost never, and remember, hardly ever, almost never a symptom of a stroke. If you ask them, are you dizzy? And they say yes, you really haven't learned much, because you have to define dizzy. Using our medical terms, are they orthostatic? Are they ataxic? Or do they have vertigo? Now, of course, those are three words you do not use with patients. But basically, if the patient gets lightheaded and feels like the electricity is going into a brownout and they start wobbling and they feel like they're going to faint, that's orthostasis. But a lot of people will call that lightheadedness, and they can call lightheadedness dizziness. You want to differentiate lightheadedness or orthostasis. That's serious, of course. The second thing is ataxia. Ataxia means that my balance is bad. If you asked a patient to do a heel-to-toe walk like a highway patrolman that suspects that you've had too much to drink, that's testing for ataxia. It's easier in the case of an elderly patient or a somewhat debilitated patient to test ataxia instead of having them walk, to simply touch their nose and touch your finger, and then you gradually move your finger, and they should be able to do that. If they're wobbling or weaving with their arm, that's ataxia. They could call that dizziness, but that's a whole different thing. Ataxia is very often a cerebellar lesion, and that could be a stroke in the posterior circulation, but those are very, very, very rare. And then the third is vertigo, and this will be the most common reason that people will say they're dizzy, and you just simply ask, do you feel like that you're still but the room is moving, that the room is spinning? And if they say yes, vertigo is almost always an inner ear problem. It's not a neurological problem. A subtle finding in thinking about stroke, if you ask the patient the standard questions about grip strength or arm drift and you're not sure, if you can, give the patient something to write with and ask them to simply sign their name. And if there is anybody else there from the family, ask them to look at their signature and see if it looks right. A patient can have very subtle weakness, and it will only be evidenced by their handwriting, and that's a fine motor test if you need that to get a little bit more information. Now, I also want to make you really a superstar in assessing for stroke. Obviously, if the patient has aphasia, they can't speak, or they have garbled speech, if they have a flaccid side of their face, if their arm is obviously weak, you got a stroke, go to the stroke center. If you don't find weakness, but you think neurologically something is not quite right, remember that the stroke can be in the cerebrum up here. It can be in the cerebellum back here. That would be real unusual, but it would manifest as ataxia. And then the stroke could be in the brain stem. And if the stroke is in the brain stem, you may not find much evidence of weakness except in the cranial nerves. And so I think it's very essential to go through some physical diagnostic tests. These are easy to do. You don't have to test every single cranial nerve. Simply ask the patient to follow a light or to follow your hand with their extraocular movements. Look up, look down, look to the left side, look to the right side, and you're looking to see if the eyes are symmetrical. If they are, then you probably do not have a problem with cranial nerves 3, 4, and 6. 5 is sensory only, so except for checking sensation on the cheeks, checking 5 is not going to be of much help. Cranial nerve 7 is incredibly important because you may see a patient that has flaccidity on one side of their face. That is not necessarily a stroke. That could be a peripheral lesion of the 7th cranial nerve, and we call that Bell's palsy. And you don't want to mistake Bell's palsy, which can be a sudden onset, just like a stroke, with a brainstem stroke that causes very similar facial flaccidity. The way you test is you ask the patient to arch their eyebrows or to wrinkle their forehead. If they can do that, that's bad. If they can't do it, that's good. Bell's palsy not only will have weakness in the cheek and the jaw and the eyelids, but they will be unable to wrinkle their forehead or to raise their eyebrows. So total, complete weakness, Bell's palsy, not an emergency. The ability to wrinkle the forehead, to raise the eyebrows, but the rest is flaccid, that's maybe a brainstem stroke. Cranial nerves 9 and 10 are fairly easy to check. It helps to have a tongue depressor, so you want to be able to see the uvula very clearly, and ask the patient to stick out their tongue and ask them to just say, ah. If the uvula stays in the midline, then probably cranial nerves 9 and 10 are intact. If the uvula deviates and or the patient seems to have a very diminished gag reflex, be careful when testing that. That might indicate something with cranial nerves 9 and 10. Cranial nerve 11 is the ability to raise your shoulders. And so that is a form of weakness. You simply put your hands on the shoulders and ask the patient to raise their shoulders. And then cranial nerve 12 is stick out your tongue. And if the patient sticks their tongue out and it deviates, say, no, please stick your tongue straight out at me. And it deviates, then that's cranial nerve 12. I think it's important, if you don't have the obvious stroke, but you feel like something neurological is going on here, check those cranial nerves. It's easy, you just have to remember to do it. And then finally, I want you to consider practicing another diagnostic test, and that is checking for reflexes. Because this can be very helpful in patients that you are not clear as to what's going on, because it really requires no cooperation of the patient. To test for a reflex, you put your thumb on the tendon that you're going to check. In this case, I would be checking the biceps tendon, and I can palpate the biceps tendon here in my antecubital fossa. If you're checking the patellar tendon, that's the classic knee jerk, Same thing, you put your thumb and press firmly on the tendon, and then when you are pressing firmly on the tendon, you take a reflex hammer. Now you can use the edge of a stethoscope if you don't normally carry around a reflex hammer, but you tap your finger. Don't tap the tendon directly, tap your finger while you're maintaining pressure on the tendon. And if you get some type of a jerk, then you compare it to the other side, because in a stroke, there is going to be asymmetric reflexes. Now, some people do not have very brisk reflexes, and so you may get very, very weak response, but you should get that on the other side. If you get a brisk response on one side and a weak response on the other, even in a patient that's not cooperative, that gives you a lot of information. The three reflexes that I would practice on is the biceps tendon, the patellar tendon, and the Achilles tendon. And the Achilles tendon, if you have a patient that is not very debilitated, if they can kneel in a chair and let their ankles relax, that's the easiest way to check an Achilles tendon reflex. Let's go on and talk about delirium. What is the difference between delirium and dementia? Both have a patient that is disoriented and confused. The difference is dementia is a chronic problem. The patient that is disoriented and confused but has been that way for several months or several years, that's dementia. Very common in elderly people. Half the people over 85 will have dementia to some degree. Delirium is acute. It's a sudden change. I was visiting with my grandfather at breakfast and everything seemed to be fine. I came back in the afternoon and he's obviously confused. That's serious. That can be an emergency. Patients with delirium typically are not healthy. They typically have fever, they have nausea, they have low blood pressure. There's something physically wrong typically. There is a rare condition where you will see someone who is disoriented or confused, but otherwise appears perfectly healthy. Everything checks out. And that patient may be having something called transient global amnesia. And it's just a sudden onset. Somebody went to the grocery store to get their shopping list, and the employees of the grocery store notice that this person is just sort of wandering around, and they say, "Sir, can I help you?" And he said, "Well, I can't seem to find my car." And he said, "Well, can we help you find it? But where am I?" And that could be transient global amnesia. That is not a stroke. That is not delirium, but it's rare. It's rare. You still want to really check them out physically. But if they really check out physically real well, that is not an emergent situation, but that's an unusual situation. Delirium has multiple causes. The most common are being on drugs, withdrawing from drugs, and infection. Those would be the major causes of delirium. In an elderly person, never leave an elderly person with delirium at their house. They need to go to the hospital. And then the third thing about assessment that I'd like to talk about is syncope. And syncope, of course, in common language is fainting, or sometimes it's called falling out. Remember, syncope is almost never a neurological problem. Syncope is a cardiac problem. And we can divide syncope sort of into two. There's very common syncope, and then there's rare syncope. The common syncope is ordinary fainting, and typically that is what we would call a vasovagal response, where some stimulus to the vagus nerve causes the heart to slow down, it causes the blood pressure to drop, and the person faints. But as soon as they get down, as soon as the blood can get to their head again, they tend to wake up quite quickly. And when you can speak to them again, and this is usually pretty quickly after it happens, they'll tell you that they did have a prodrome. They were feeling somewhat lightheaded. They felt like the lights were dimming. They felt sweaty. They felt nauseated. They felt somewhat short of breath. A person that has the rarer or more serious syncope will not have any prodrome at all. It just happens. The other thing is that people who have a vasovagal reaction or a faint almost never injure themselves. They somehow manage to fall without hitting the corner of the desk. And so the patient that faints rarely will have actually injured themselves. If you see someone who has fainted and has a big gash on their head where they hit the nightstand, you need to worry that you're not dealing with simple fainting, that you may be dealing with a more serious problem. So what is the serious syncope? The serious syncope is a cardiac arrhythmia. And this could be VTAC, in which case the patient, of course, will have no blood pressure and will obviously need to have some electricity administered. But they may be simply having heart block. Third-degree heart block can come on suddenly. The patient will have a pulse, but it will be very slow. So in the patient that the history that is given to you says they just fell like a tree that was cut. There was no prodrome. Just all of a sudden they just fell. You want to get a monitor on them quickly, and you want to assess, obviously VTAC would show up. Third-degree heart block is pretty easy to diagnose, but look for subtle changes because the patient could have had complete heart block, and now all you see is Winky Bach, or you see first-degree heart block. But if you see any evidence of heart block, then you know that probably you're dealing with some type of a cardiac problem, and that's an emergency, and that needs to be tended to. Another thing that I would simply like to mention in assessment with the neurological exam is malingering, because if there is any organ system where people can rather successfully mimic a neurological problem, that's where malingering will sometimes show up. The important thing about malingering is you must not assume that as your primary diagnosis. That has to be what we used to call a wastebasket diagnosis. That's what you diagnose when you have ruled out everything else. Someone who is faking a seizure still needs to stop the seizure. A patient that is faking paralysis, that you need to treat as a stroke until proven otherwise. But there are some subtle tests that you can do for malingering. Most of those you probably already know. One thing is to very, very gently stroke the eyelashes. If you see any type of eye movement, then you know that this is not a deep coma. Seizures can be very difficult. I remember once we had a patient that we just absolutely were concerned about because we had administered IV Valium 3 times and the patient continued to seize. I became suspicious that there might be some malingering involved, but I wasn't sure. So I just, in a rather clear and loud voice, spoke to the paramedic that was with me in the back of the ambulance and said, it seems that the patient is unresponsive to our usual treatments, so it may be necessary to paralyze her and to intubate her. And at that moment, the seizure stopped. So sometimes that type of thing can work. But I mention that because I want to make a point, and that is never threaten a patient. Never threaten a patient. Never say, cut out that or we're going to do this. Never threaten a patient. But you can speak about possible consequences that might be necessary. That's a different thing. The other thing is, do not ever use pain as a way to test for malingering. Never, in a paralyzed patient, take a pin and stick them on the sole of their foot to see if their leg moves. That is completely unacceptable. But there are some subtle tests that you can do that are not painful at all. One is reflexes again. Test reflexes. It's almost impossible for someone to deliberately show a decreased reflex in one part of their body, on one side of their body, and not on the other. That's very difficult for anyone to fake that. And if you're adept at testing reflexes, that can really help you. The other thing is, for the patient that is complaining of paralysis, particularly paralysis on one side of the body, put the heel of the paralyzed side in your palm and just put your hand under their heel very unobtrusively. And then ask them if they could please raise the non-paralyzed leg. And someone with a stroke should, of course, be able to raise that leg. Somebody that's faking paralysis will raise their leg. The difference is, if there's true paralysis, they can't press down. That side is really paralyzed. Someone that is faking it, if they raise this leg automatically pushes down for support. And so if you feel pushing down on your heel, you know that side's not paralyzed. So once again, never threaten, never use pain, and learn some techniques that can help.